once I have a good feel for the person, the work is going well, I stop thinking diagnostically and simply immerse myself in the unique relationship that unfolds between me and the client. One can then throw away the book and savor individual uniqueness. I want you to hear Nancy's words, because what people will think, and you pass that book, Psychoanalytic Diagnoses, it's pigeonholing people. If you've ever seen her do a workshop, I really recommend it. She is very kind, very empathic. So I want you to understand her meaning of a diagnosis. Its usefulness in treatment planning, these are the different reasons for diagnosing. Understanding character types. Help the therapist be more careful with boundaries with a hysteric patient, more pursuant of flat affect with the obsessional person, and more tolerant of silence with the schizoid person. Tomorrow I'll be talking more about how to use diagnosis with psychotherapy, informing therapy. Number 2, implications for prognosis. Having realistic goals protect the patients from demoralization and therapist burnout. I've supervised a lot of therapists working with patients at a borderline personality structure or organization. And their goals are unrealistic. And they're saying, why am I doing this? It's not getting anywhere. And I interpret to the person their own needs to feel effective. And they're not conceptualizing this person. And the person is feeling the frustration from the therapist. You really don't need that. It's not good for the patient. It's not good for the therapist. Its value in enabling the therapist to convey empathy. Once one knows that a depressed patient also has a borderline, rather neurotic level personality structure, the therapist will not be surprised if during the second year of treatment she makes a suicide gesture. Or once a borderline client starts to have hope of real change, that he often panics and flirts with suicide in an effort to protect himself from traumatic disappointment. Is that, Ken, we're missing a little part of that. But anyway, I'm sure many of you experience that just when somebody that has a character structure, and I'll talk about personality organization, character structure at the borderline level, they're doing well and you want to know, oh my God, they just had a serious suicide attempt. They have to be hospitalized. Things were going well. Knowing that they have that borderline structure will help you to anticipate it, not be blindsided. Know what to do. This is very, very typical. Because you're dealing not with symptoms, but a person with an identity that's always been with them. This is not things they have. This is who they've been. It's part of them. And they start to make progress, and all of a sudden something is dying. Dying. And, in terms of transference, being murdered by you. Give an example, and I do this when I explain resistance sometimes to some of my more insightful patients. I said, let's say we're in the future and psychopharmacology is really advanced. We have now a pill. And you've been suffering your whole life with serious problems, really unhappy. We now have a pill that would get rid of it. One pill, it's gone. Would you take the pill? Oh, yes, I would. The side effect is it wipes out all your memories, your whole identity. You start afresh. Everyone you've ever known, or your friends, all your memories have to be erased because they carry with it all the issues. Now, would you take the pill? Guess what they say? No. Because you know what it is? It's murder. It's soul murder. That's the heart of all resistance when you really look at it. It's not something being uncooperative. Person comes in and says, I have a lot of anxiety. Okay, let's start working with desensitization, facing your fears, looking at your rational thoughts, or more psychoanalytic. Anxiety is a signal affect. It's signaling that something may be breaking through that you're not supposed to be doing. Okay? Whatever level you work at, they all work pretty much well the same. And then you realize that it's not just anxiety. This person has a hard time just growing up, maybe being very dependent. Maybe the anxiety allows them to not do certain things. and get certain interpersonal needs met. And now you start doing things about who they are as a person. And then they're saying, this guy's changing me. My mother did that in a way that hurt me. This guy would do the same. How do I know? At least I know who I am. This treatment may take away who I am. It'll murder me. That's when you're going to get a suicide attempt. If they're borderline, the neurotic will say, I ran out of money. Insurance isn't paying for it anymore. Or I got another job. And I'm sure I don't have the time to continue this. That's that fear of messing with someone's basic sense of self. And when you have a good diagnostic picture, you anticipate that. And what I say in the beginning, when I'm educating my patients how to be a patient in psychotherapy and any kind of therapy, what I'll say to them is, oh, by the way, you decide when we're done. But when you feel like you're done, check it with me, because there's a lot of decisions that are coming from different sides of your personality. I don't need to keep you in treatment. I'll have somebody else after you, but I'm dedicated to helping you. Come in and talk about it. There will be a day when you'll want to leave prematurely because you're about to make big changes. When you make big changes, it's changing parts of you. And those parts aren't going to pack their bags and say, okay, I'll look for somebody else to haunt, to invade. Those ego states just don't go away. They're listening to the therapy. They're smarter than you, because they got more of their unconscious accessible than you have. You only have the conscious part. They're updating ways to make you miserable. Okay? And there's going to be a time you're going to flee therapy because these parts of your personality are going to say enough. That's when you come in, talk about the urge to leave, and we'll see about the reasons, if they really make sense. We'll see if you still have symptoms, what your mental life is like, what's going on. I prep them for it because I have a good diagnostic picture. That's going to be more important with the hypomanic type personality, the counter-dependent personality. That's not in the DSM. That's in the PDM. Okay, and I just talked about this. Okay, its role in reducing the probability